fix the bites. And then, in your mind, you will fix the bone. And then trying to move teeth inside the bone. But if you are thinking about bone driven, for me, I'm thinking about, okay, fine, how am I gonna move the bone? Either surgically or non-surgically. If that is possible to move the bone non-surgically, so if you think differently, your action will be different. Trust me. So think about the jawbone. Well, you can do orthopedics. You can destroy the suture, but in terms of the patient, which jawbone is very easily to be driven without surgery. I'm speaking which bone is moving. Our mandible. So our mandible agent can move up and down, right and left all the time. But the maxilla cannot. So the only jawbone that we can move easily without surgery by tooth movement is mandible. That means, okay, fine, for trachea adult patient. I'm thinking about the bone driven. The bone driven, that means how I can move the bone, especially the mandible. So now, because my thinking process is different, so the action of mind will be different. So how will I move it? How will I drive the bone, the mandible? The first thing is, because I'm concerned about two things about plastic patients. One is how much the chin projects. The chin projection means from the soft tissue pogonium to the neck. That is the chin projection. The chin height means the distance from lip to the soft tissue membrane. That is the height. Why I'm using this? Because my patient, they always come to me, hey, I'm really concerned about the height, the length of my chin. It's not even this way, but also this way as well, the vertical one. So I consider height as well. So my action will be, because I'm thinking about bone driven, so my action will be, okay, I'm fine, I'm gonna use razor to control the chin projection, back and forth. The second thing is I'm gonna use bone screw test to control for the chin height. So this is what I'm thinking. Instead of moving teeth back and forth to fit into class 1 occlusion. So what is the razor? Well, the razors I make it from a glass ionomer cement that I use to cement band. Or if you prefer use other razor will be fine, because the price of the razor will be higher than the GI cement. Well, if the patient has a chin deviation and also have occlusal cane, I would like to put the razor on the side who has no cane, because that also help to into the molar so that I can label the occlusal cane. Don't forget about that. When you put razor, when the patient bites, that also into the molars. So don't forget about the intrusion of upper molar or lower molar. Either you put it in the upper or lower. So because I put it on one side, so that would be a better idea that you put a TPA or the overhead arch in order to balance right and left, also to reduce the amount of molar intrusion. Of course, because the molar can be intruded, and also the GI cement can be treated away. So you would like to add the height of the razor every month when the patient comes back. So that is the way that I do it. Of course, this technique also fits for growing patients or adult patients, if you prefer. So I'm now using both of in my growing and adult patients. I used to do a lot of auto-RMS, as you know. But now since auto-RMS, to be honest, I have to put on expander. If I can only put on braces and wire them, I can deal with the maxilla mandible. That would be perfect for growing patients as well. So, if you like to have a journal article to look at the details, there are two articles that you can quote. Is one in 2018 in APOS trend in orthodontics, in 2022 in APO. And please, when you write your paper, please quote these two articles. Also, especially APO trend in orthodontics because I'm editor-in-chief for that journal. So please help me to increase our effort. Thank you. So, is there any difference between using biorazor test among that low-angle patients, average-angle patient, and high-angle classic patients? In terms of controlling the chin projection and also the chin height as well. I think they do have some differences. And that is the purpose I'm here today to show you what are the differences between those patients. So the first example is this very low angle class 3 patient, 22 years old. Her chin complaint underpied long and crooked chin, and also with a right side cancer clicking when she is open. So you can tell not only mandibular prognathism, she also had a chin deviation as well to her right side. So CT scan, I don't have to explain. That is a very low angle. Okay, a major hypoplasia and mandibular prognathism with chin deviation. A chin deviate to the right for 2.5 millimeter. Intraoral, you have a class 3 backward occlusion and the post-spike party, lower denominator off to the right with a chin deviation, procline upper entities, and retrocline lower entities. So let's start this slide here. Think about that. If you are thinking about occlusion-driven treatment philosophy, you gotta fix the lower jaw. So you can see spatula on the left side. Class 3 canine are two differences. That means if you want to retract the lower canine, you have to retract whole tooth width. That's a lot. Then you will believe, no, I won't be able to do it. Let's have a jawbone surgery. Because you are thinking in occlusion. You are thinking about how can I move the teeth to fit into crosswalk. But I'm thinking differently because my thought is bone driven. So what I'm thinking about is how can I move the bone before I move the teeth? So this is what I did. So right at the beginning, after I bone the bracket and put on the wire, second month when the patient came back, I put on the biorazors. What is the purpose of biorazors that I mentioned? I use it to reduce and control the chin projection. Once you put the bone back, that means the occlusion will become more class 1. To look at the right side canine now, is a little class 2 now actually. And look at the left side, almost class 1. So the left side used to be like, have a whole tooth width difference for the class 3 canine relationship. Now it's almost class 1. I think every one of you over here, when you look at this slide, disregarding the open bun, then you think, are you able to treat this malocclusion? Yes, of course. Do I need to remove any tooth? Of course not. Why is that? Because there's a very important concept that is bone driven instead of occlusion driven. So I keep it for that. Regarding biorazors, should I use one side, both sides, right or left? It's up to you. I prefer to use on one side. She was one of my earlier patients, so I put it on both sides because I didn't know actually I could also put it on one side. So if you are putting it on both sides, I suggest to put it on second molar first, and then if you see intrusion, then you remove that, move to first molar. Then after that, if you see first molar have intrusion, you move back to second molar. So alternatively, you go between second, first, something like this.